is Alfred Chung, Division of Nephrology. I have been tasked by Dr. Cooney to introduce this morning's speaker, who is Dr. Jeff Sands. Jeff Sands is old, not chronologically, but just been an old friend of our division who knows many of us for decades. And Jeff went to get his MD degree in Boston University and went to NIH to work for a few years in NHLBI, and then went to Emory, where he started as a fellow and climbed up to the rank of full professor, endowed professorship, and then chief of nephrology in 2002. And then he also took a lot of responsibility in both the institution and the department. And the department, he is executive vice chair. And the School of Medicine, he is the associate dean for clinical and translational research. Jeff has all the appropriate title that I would not go into: ASCI, AAP, and Distinguished Achievement Award from American Heart Association, etc., and many important positions locally and also professional society and the NIH. That is about the extent I want to detail his very, very long CV. That funded by NIH for decades. So what Jeff, one of his major contribution is understanding, discovery of the pioneer work on the urea transporter in the kidney epithelium. And it is, may sound esoteric, but it's actually of great clinical implication, for which he's going to tell us a little bit more about how much trouble when patients cannot concentrate their urine, how it affects them physiologically and clinically. So welcome to Utah, Jeff.
Well, thank you, Alfred, for that very kind introduction. I probably am old chronologically, as well as having many friends for many years in the audience. And what I'd like to tell you about this morning is really work that's led to what could be some novel therapeutic approaches for a disease called nephrogenic diabetes insipidus. And although this is certainly not the most common disease that one runs into in internal medicine, I think almost as important as what we may discover for patients is really, and particularly for the residents and the students, to see what a physician scientist can potentially contribute in terms of the process of doing fundamental research and then following that fundamental research with keeping an eye on the patient at the other end, and how you can actually take fundamental research, look at those insights, and ultimately have it lead to discoveries that hopefully will improve care at the bedside. But that process, the importance of fundamental research for physicians to be engaged in, the dying breed of physician scientists, hopefully this is just one example, and I'm sure many others as in various disciplines. So let's see. So what I hope to do for you in the next hour is review the urine concentrating mechanism, review transcellular water transport, review nephrogenic diabetes insipidus, and review the dysregulation of water channels and some other common clinical conditions. And unfortunately, I actually have no relevant financial conflicts of interest, because if we had actually made this to the bedside, I probably would. So maybe my next visit here, I'll have to disclose something. So there are many clinical conditions associated with abnormal water balance. Many of these conditions are ones that, as internists, you've run into. Certainly in adult medicine, patients on lithium therapy often develop nephrogenic diabetes insipidus. Profound hypokalemia, not just for a day, but patients who are hypokalemic for a week or two with potassiums less than 3 develop concentrating defects. Low protein diets and protein malnutrition, hypercalcemia, even a few days of hypercalcemia of a fairly mild nature, calciums of 12, 13 can lead to a concentrating defect. The one we'll focus on today is diabetes insipidus. I'll show you a little bit about aging at the very end of the talk. Diabetes mellitus can do it, as well as adrenal insufficiency. So let's start with a clinical case. This is an actual case. It's not a patient I saw, but on the next slide you'll see the reference. It's in the literature of a 53-year-old white male admitted for a neck cancer, long history of bipolar disorder, treated with lithium, and has a surgical procedure, and his fluids at the end are, of course, D5 half normal, because half normal is always half right and half wrong, so it's one of the favorite solutions of the surgeons. Serum sodium is 151. Patient is allowed to drink, and they find that his 24-hour oral intake is 7 liters, including the IV fluids, 10 liters, and he's putting out 8 liters. So certainly this patient is profoundly polyuric. On post-op day 3, sodium still 145, urine output 5 liters. They now go back and take a more detailed history. And they find out he's actually had a history of polyuria and polydipsia for several years. The patient would awake at night 3 to 4 times to urinate and drink water. And as is often classic for lithium-induced nephrogenic DI, the onset was insidious. So over time, it kept getting worse and worse, and the patient really didn't think much of it. It just slowly came on, and he adapted to it by increasing his fluid intake. So until you did a careful history, this was not reported by the patient because he didn't recognize it as abnormal. And down here is actually the reference for this case. So let's start by looking at the urine concentrating mechanism. Now, I know that this is a slide that strikes fear into the hearts of attendings, residents, and medical students, but we'll go through it anyway. This is my view of the nephron. You have a glomerulus, proximal tubule, here you have the loop of Henle, distal nephron, and collecting duct. When it comes to the urine concentrating mechanism, the glomerulus and proximal tubule are largely irrelevant. That's because even though 60 to 80% of the glomerular ultrafiltrate is reabsorbed in the proximal tubule, it does so isosmotically. There is no separation of salt and water by the proximal tubule. So the action is entirely in the medulla, and most importantly, by the sodium-potassium 2-chloride cotransporter located here in the thick ascending limb. The potassium recycles on another protein called ROMK, so the net result of this transporter is to take salt out of the lumen of the thick ascending limb and add it here to the interstitium. This is the transporter that is inhibited by all the loop diuretics. Furosemide, bumetanide, any of the etinides, they all work by inhibiting this transporter. But the net result is 2 very important things. First, you get dilute fluid delivered here to the distal nephron. People can dilute their urine to as low as 50 milliosmoles. Can't get any lower than that. So in the absence of endogenous ADH, antidiuretic hormone, or vasopressin, which is another name for the same hormone, the collecting duct is virtually water impermeable. So probably about now, you've probably all had a bunch of coffee and suppressed your endogenous ADH levels. You're going to be making dilute urine by the end of this hour. And what happens is this dilute fluid here, due to the removal of the salt, is simply excreted in the urine. The collecting duct has virtually no water permeability. But probably a few hours ago, when you first woke up after not having any fluid overnight, your ADH levels were quite high, and you produce typically quite concentrated urine in the morning. And that is because you have high endogenous ADH. The interstitium here, medullary interstitium, by adding salt and countercurrent multiplication, increasing that concentration of salt, so that in people it's around 1,200 milliosmoles here, water can now be reabsorbed. These aquaporin water molecules that we'll talk a lot about in this hour, aquaporin 2 in particular, are inserted into the membrane of the collecting duct, and if there's a hypertonic medulla, water is reabsorbed osmotically down the length of the collecting duct, and you excrete a highly concentrated urine. Now, in addition, There's solute that's left behind in the lumen of the collecting duct. This is progressively concentrated until you get to this last two-thirds of the intermedullary collecting duct, where now, through the action of the urea transporters, urea can be reabsorbed and add to the tonicity of the intermedullary interstitium. These are the proteins, as Alfred said, that I've really studied most of my career, although we won't really talk about them today, but that's where they're located. And to some extent, urea gets secreted back into the thin ascending limb, and sodium chloride is reabsorbed, and as long as more salt comes out than urea goes in, it adds to the concentrating ability, but it explains, in some ways, the critical importance of urea and why low-protein diets and protein malnutrition give you a concentrating defect. But that's the basics of the so-called passive mechanism. The key points to take away from this is that the NKCC2, the transporter inhibited by loop diuretics, is critically important for both dilution and concentration. So if your patient is on a loop diuretic and they're compliant, they should be producing urine of 290, 300 milliosmoles. They won't be able to concentrate or dilute because you've inhibited the key transporter located here. To make dilute urine, you simply get rid of it. Concentrated urine is the action of the aquaporins under the action of vasopressin. So there are quite a few aquaporin molecules now. In fact, we're up to, I think, about 13. Starting with 0 to 12. Aquaporin 1 was the first really named aquaporin. This was discovered by Peter Agre. He won the Nobel Prize in Chemistry for this discovery in 2003. I understand Peter's going to be visiting shortly, so maybe this will whet your appetite for Peter's visit. Peter's a fantastic guy and is probably the most humble Nobel laureate I've ever had the pleasure of meeting. It's in the proximal tubule, as is aquaporin 7. The collecting duct is aquaporins 2, 3, and 4, and aquaporin 2 is the one that's in the apical membrane and is regulated by vasopressin. This is taken from Peter's work, and it shows the actual structure of aquaporin. All of the aquaporins follow the same basic pattern of 6 transmembrane spanning regions, and then they have these 2 long loops here that actually fold back into the membrane, and that's shown here. And these NPA motifs form what looks to be a hole where water can actually go through. There's a cysteine here, and for the older members of the audience, you may remember mercurial diuretics. Of course, they're not used now because they're fairly toxic, but mercury would inhibit this cysteine, and that was how they worked as a diuretic, was by inhibiting water transport, by inhibiting that cysteine. In biological membranes, the aquaporins exist as a homotetramer. Why they're always as 4, maybe Peter knows the answer. I've not ever read one, but the water goes through these 4 holes. So each of these in an oocyte, for example, will transport water, but in mammalian membranes, they form a tetramer, and Peter named this the hourglass model of aquaporins for the obvious reason that it looks like an hourglass. Now, we've talked about vasopressin, or antidiuretic hormone, and there are actually 2 types of receptors for vasopressin. The one that we're going to talk that matters for concentration is the V2 receptor. Makes the collecting duct permeable to water. It's a G protein coupled 7 transmembrane spanning receptor, and it works through cyclic AMP. When you're giving vasopressin in the ICU setting, you're not doing it to stimulate the V2 receptor, you're doing it to stimulate the V1 receptor. This has 2 subtypes. This is to increase blood pressure in vasculature, liver, and brain, and it works through a different second messenger. So how does water get across a collecting duct principal cell? Well, here's a cell. This is the lumen of the tubule, or what would be the urine-facing side of the collecting duct epithelia. This is the interstitial or blood-facing side of the epithelia. The V2 receptor is on the blood or basolateral side of the cell. Vasopressin binds to the V2 receptor activates adenylyl cyclase, generates cyclic AMP, activates protein kinase A, that in turn phosphorylates aquaporin 2, which lives in these subapical vesicles, and causes their insertion into the apical membrane. Water can then move transcellularly across the cell, entering through aquaporin 2 and exiting through either aquaporin 3 or aquaporin 4. When the vasopressin stimulus ends, the aquaporin 2 molecules are endocytosed, and they go back to these subapical vesicles where they recycle, so that they're not degraded, but for the most part they go here with vasopressin, and then when the stimulus ends, they're re-endocytosed, waiting for the next phosphorylation and re-entry into the apical membrane. This model was actually proposed in the late 1970s by Jim Wade and called the shuttle hypothesis. It took about 20 years later to get experimental proof of the shuttle hypothesis, and that is shown here. Dr. Kishore was probably in the lab when this study was done. I can't remember if he was a co-author or not. But this paper shows you proof of the shuttle hypothesis. Let me show you what you're looking at. So this is electron microscopy of a principal cell in a perfused intermedullary collecting duct. And what the authors did is they measured osmotic water permeability either before adding vasopressin, following vasopressin, or after removing the vasopressin. And after each of these periods, different tubules of course, but they would harvest the tubules off of the perfusion pipettes and fix them for electron microscopy. Now this is incredibly technically difficult. These tubules are about 0.5 millimeter long and 20 to 30 microns in diameter. So it's hard enough to actually microdissect these and mount them on pipettes for perfusion, but then to actually harvest them off the pipettes and find them. I mean, you're looking for something that's, you can't see. This is the proverbial needle in the haystack, but to find it and do electron microscopy is a real technical tour de force. But what they found, let's look first at the water permeability. Before vasopressin, it's low. It goes way up with vasopressin, comes down when you remove vasopressin. Shown here are black dots, which is immunogold electron microscopy, showing you the aquaporin 2 molecules in these subapical vesicles. And there are arrowheads here so that you can see the dots better in the back of the room. There's some in the apical membrane, but very little. When you then take a tubule that's been exposed to vasopressin, if you just look at the arrowheads, you'll see they're all now, or virtually all, in the apical plasma membrane, far fewer in these subapical vesicles. And if you quantitate that, you can see here's before vasopressin, here's with vasopressin. When you remove vasopressin, it comes back down to the pre-levels, and I don't have that shown here, but it actually looks very much like this picture here. So this was the first experimental proof of the shuttle hypothesis. Now, what we've talked about is really the rapid regulation of aquaporin 2, with vasopressin stimulating insertion of aquaporin 2 vesicles into the collecting duct membrane and phosphorylation. But there's also long-term regulation of aquaporin 2, which involve changes in gene transcription, changes in protein abundance, and these are both vasopressin dependent and independent. Now let's look first at some animal data that supports this idea of long-term regulation. This study was done in a Brattleboro rat. So a Brattleboro rat actually came from Brattleboro, Vermont. It's an animal that has central diabetes insipidus. It's just somehow a naturally occurring rat that has a mutation that so it doesn't make and secrete vasopressin. I don't know how it was discovered. Legend is the trail of urine left behind in the snow in Brattleboro, Vermont, but that's what the rat does. This is, again, histochemistry of the intermedulla from these animals. Here's vehicle-treated animals, that is just regular Brattleboros, almost no aquaporin 2. When you treat the animal with vasopressin for 3 to 5 days and do the same thing, you can see much more aquaporin 2 immunostaining, and most of it is at the apical plasma membrane. This panel here is just a blow-up of this one, so you can better see that the aquaporin 2 is really at the apical membrane. And this is quantitated here. This is aquaporin 2 expression before and after vasopressin. This is 3 to 5 days of vasopressin, and tubules from these animals were perfused, and this increase in aquaporin 2 protein is functional, as evidenced by the increase in water permeability. Now, this is a fairly, well, to me it's a recent paper. It may not seem that way to the students in the audience, who may not have even were in elementary school at the time, but we all should have known that this could be, because here it really is an older paper from '57. This was a paper that looked at people. The authors are DeWardner and Herxheimer. There were 2 experimental subjects, DeWardner and Herxheimer, because that's how clinical research was done back then. They experimented on one another. And what they did is they induced psychogenic polydipsia in themselves. That is, they each drank 10 liters of water a day for 11 days. And they measured urine osmolality following water deprivation or exogenous vasopressin, either before the water drinking or at the end of the water drinking. So I don't remember which color is DeWardner and which is Herxheimer, but it doesn't really matter. You can see before the water drinking, they both made urine of 1,000 to 1,200 milliosmoles, either just their first morning void, or after an injection of exogenous vasopressin, no change, because they were maximally concentrated. Following the 11 days of water drinking, they now make urine of around 500 milliosmol, and again, no benefit from exogenous vasopressin. So we all know this to be classic psychogenic polydipsia. When you stop the water drinking, initially they can't concentrate normally, and it takes several days until they are able to recover their ability to concentrate. And this suggests long-term regulation of urine concentrating ability. Now, for reasons that actually never made any sense, this has often been explained as washout of the medulla. Well, when you think that 25% of your cardiac output is going through your kidneys at any one time, it should not take very long for more than enough solute to come through your kidney to begin concentrating your urine again, unless the machinery needed to make use of that solute has been downregulated. And the modern interpretation would be that with prolonged water drinking, the kidney says, okay, I'm being flooded with water, I'm going to turn off aquaporin 2 gene transcription, I'm going to downregulate NKCC2, I get it, tons of water, I don't need these proteins. When you stop the water drinking, you now have to activate these genes, make the proteins, put them back in place so they can take advantage of all the solute that's coming through. So let's turn now to a disease condition. And this is one called nephrogenic diabetes insipidus. Now that we understand the basics of transcellular water reabsorption, of the urine concentrating ability in a more modern context, let's see if we can take that knowledge and use it to understand a disease and maybe even come up with novel therapeutics. So these patients produce very large quantities of dilute urine because the kidney is unresponsive to vasopressin. How much? Well, in kids with congenital NDI, they can make 20 liters of urine a day in the severest forms. Think about that. That's a liter an hour, 24/7, 365. And they have to drink 20 liters to stay in balance. For those of you who either have or had young kids, think about how many diapers that is to change if your kid is making 20 liters a day. Nobody gets any sleep. The kid can't sleep, and certainly the parents can't sleep because the parents are up changing diapers and giving the kid water. Eventually the kid, they get to the point where they can drink water themselves and they get potty trained, and the parents now get some sleep, but the poor kid still doesn't. That's the very severest form. We don't see much of that in adult medicine, of course. It's more in pediatrics. But what we do see in adult medicine are patients like the one at the start of this talk who take lithium. They usually don't make 20 liters a day, but they could easily make 5, 10 liters a day. So most cases that we see are acquired mostly due to lithium, although there are other medications that can cause it. The hereditary cases are about 10% of the total. 90% are mutations in the type 2 vasopressin receptor. This is an X-linked mode of inheritance, so obviously it's only the male children that are affected. The other 10% are mostly mutations of aquaporin 2, although some other proteins can do it, and these can either be autosomal dominant or autosomal recessive. And why would this, and now you probably understand why these mutations would cause the disease. Because a mutation in the V2 receptor means that vasopressin can't bind or activate the receptor, so nothing downstream happens. And mutations in aquaporin 2, of course, means that there's no water channel there to reabsorb the water. Well, if you have a mutation in the water channel, the potential ways of treating that are limited. It's basically gene therapy or some other way of correcting the mutant water channel, none of which exist. But in theory, if you have a mutation in the V2 receptor, the rest of this machinery is normal. So if you could find ways downstream of the receptor to activate this process, or particular to get aquaporin 2 into the membrane, you may be able to come up with a therapeutic approach. Now, there are many different mutations that give in the V2 receptor. It's not like sickle cell disease where only one amino acid is mutated and everyone has the same mutation. This is now an older slide from Daniel Bichet's work, but each of these red amino acids is one in which a mutation of some family exists which has a mutation at one of these red dots that gives them NDI, congenital NDI. So you have to actually know in a given family what the genetics are to figure out if an at-risk infant has the disease. And that's important because if you go back to the literature of the 1980s, it says that mental retardation is an inherent part of the syndrome of congenital nephrogenic diabetes insipidus. In fact, it's not. If you prevent the bouts of severe dehydration that these infants experienced by giving them water, enough water to stay in balance, they don't develop any neurologic abnormality. I've met some of these children. In fact, I know some who are in college now. So there is no mental retardation as part of the syndrome. But for whatever reason, prior to the cloning of these receptors, the V2 receptor and the recognition, it was thought that it was just part of it. Now, aquaporin 2 also is mutations at each of these red circles has, at least in some family, been reported as causing nephrogenic diabetes insipidus. So, how does lithium work? Lithium, which causes an acquired NDI, works by inhibiting adenylyl cyclase, which prevents the generation of cyclic AMP and again the rest of the downstream signaling. So with lithium as well, if you could again find a way to activate downstream of this block, you could potentially do something to benefit the patient that we talked about at the start of this lecture. So the other important point about lithium, and you probably are all aware of this from your clinical experience, although you may not have actually thought about it, is that lithium, when you stop lithium, it doesn't always reverse the process. And in fact, in most patients with lithium-induced NDI, when you stop the lithium, it often doesn't get better. It seems to cause an irreversible problem. This is at least an example from an animal study that we did at Emory. Mitzi Blunt, who's a colleague at Emory, did this study. And what she did is she gave lithium to rats and measured aquaporin 2 protein abundance. And this is a Western blot showing you aquaporin 2. What matters really is to look here at the averages. So this is how much aquaporin 2 is in a normal rat, After 7 days of lithium, it's markedly decreased, even a little more at 14 days. But when you stop the lithium at 14 days and look at 7 days, it's still not back to control levels. And even at 14 days, it has not come back to control levels. So there's something about lithium. Once it gets into the cells, it really doesn't have a good way to get out of the cells and can often cause irreversible changes, not only in concentrating ability, but it can also lead to chronic kidney disease. I'll give you a few more pretty pictures here about other forms of acquired NDI. I mentioned hypokalemia. This is for about 2 weeks of hypokalemia. If you look here, this is aquaporin 2 in a control animal. Here's aquaporin 2 in a hypokalemic rat. Whether you look by immunofluorescence or histochemistry, you can see there's much less aquaporin 2 visible. Same thing by Western blot. And again, a study that I did in collaboration with Bill Harris many years ago. We looked at hypercalcemia. This was just 3 to 4 days of hypercalcemia with calcium, about 12.5 in these animals. And you can see, again, less aquaporin 2 protein by histochemistry, less by Western blot. And in this case, we perfused tubules from these animals. And you can see here's normal animals responding nicely to vasopressin. Here's the hypercalcemic animals not responding to vasopressin. So in acquired NDI, whether it be lithium, hypokalemia, hypercalcemia, they all result in a decrease in aquaporin 2 protein and a decrease in water permeability in the collecting duct. And with the decrease in water reabsorption, even in the presence of vasopressin, gives you an NDI. So how can various groups, including members of the audience, have really been tackling this problem in the last decade, looking for ways to come up with therapies that may improve the situation, either for the congenital or for the lithium-induced NDI. And here's a list of things that there's, and I'm going to review each of these briefly. These are some novel therapeutics that people have come up with that seem to not only show efficacy in animal models, but there's even some hints that they could be useful in people. An important point here is many of these are medications you're already prescribing. So these are commercially available products which they're not indicated for this disease, but they're available, their safety is known, and so potentially the pathway to translate these from the bench to patients will be a little shorter because they're already on the market. So let's look first at sildenafil. Sildenafil, I mean, if you watch football, this is only advertised about every other minute, but that's not why it's being used here. So sildenafil has effects on cyclic GMP. This is a study from Dennis Brown's work and was really the first one that went in this direction. And what Dennis's group found is he looked here and measured the amount of aquaporin 2 in the plasma membrane. So this is done in a Brattleboro rat, so it's not nephrogenic, it's central DI, but here's the aquaporin 2 in a control tubule. Here's following vasopressin. You can see that it's now much more at the apical membrane. And here's sildenafil, and the effect is almost as nice as with the vasopressin or the DDAVP. And quantitatively, you can see the result here. Vasopressin has a very marked increase in the amount of the apical membrane. Sildenafil, not quite as good, but certainly better than control, suggesting that in some way cyclic GMP, a different second messenger, may be able to get aquaporin 2 to the membrane even though the cyclic AMP pathway is blocked. Now last year, a paper came out in which someone actually decided to try this in a patient. Again, I'm not advocating for the use of off-label of anything, but somebody did this, and it was published last year. And they took a 4-year-old boy with X-linked NDI, which was resistant to conventional therapy with thiazide and nonsteroidals, and treated him with sildenafil for 10 days. This actually was not done in the US. It was done, I believe, in India. But regardless, and what they found was that sildenafil reduced 24 urine volume, and this child did not have the 20 liter an hour version, but he did have NDI making about 1,700 mils per day, and it was cut in half, and serum sodium improved, no longer hypernatremic, back to normal, and urine osmolality doubled. So this is really very encouraging that the approach of the sildenafil may be beneficial. Now the problem with the sildenafil is it increases blood flow. I mean, that's why it's on all the football games. But it also increases renal blood flow. And so by increasing renal blood flow, it tends to work against improvement in urine concentrating ability. And in the Dennis Brown paper on the previous slide, when they gave sildenafil to the animal, they did not see an improvement in urine osmolality, because even though there was more aquaporin 2 in the membrane, they had increased renal blood flow, and the two effects balanced each other out. But this study here in an actual patient suggests that maybe there could be some benefit therapeutically. Another approach that Dennis Brown's group took was looking at simvastatin. Now, simvastatin changes the cholesterol content of the membrane, and they reasoned that by changing the cholesterol content, you may be able to alter the amount of aquaporin 2 in the membrane. This shows the urine output. This is again in a Brattleboro or central DI animal. Here's what the control animals make. Here's what the animals treated with simvastatin make. You can see an obvious decrease in urine output. When they looked at it by hourly, you can see here's control versus these different hours of simvastatin, 3 controls, the same 3 here, and the 3 simvastatin. The problem here is that the effect wears off. So they got a really nice effect for a few hours, and by 5 to 6 hours, the effect had disappeared. But this led other investigators, this group in Italy, to ask the question of whether, gee, we give lots of patients simvastatin. Is there any effect of simvastatin in people who are simply getting simvastatin for hypercholesterolemia? And so they took 24 naive hypercholesterolemic patients. This paper just came out this year. And they measured the urine excretion of aquaporin 2 as a biomarker of aquaporin 2 in the apical membrane at baseline and 12 weeks after treatment with simvastatin. And they found that simvastatin induced a rapid and significant increase of urinary aquaporin 2, reduced the 24-hour diuresis, and increased urine osmolality, and these effects were maintained for at least a year. So this is, again, very encouraging that simvastatin may well benefit patients with NDI. This is not NDI patients. These are just your everyday patients who come to your clinic and you start on simvastatin, but it's certainly intriguing and would merit being tested. Another approach that's been taken is chaperone therapy. So you may say, what is chaperone therapy? The pulmonologists in the group, I don't know if there are any pulmonologists in the group, are certainly familiar with this from cystic fibrosis, where the most common mutation in cystic fibrosis is the delta F508 mutation, which, if you could get that protein to the membrane, has partial function. But normally it's destroyed. The ER's job is to degrade mutant proteins. And there are now medications that are given to CF patients that help take that mutant protein and actually get it to the membrane and then activate it in the membrane and are beneficial in CF. So that concept of mimicking what's done for cystic fibrosis has been explored for nephrogenic DI, because some of the vasopressin receptors, the mutant receptors, do have some partial function if you could get them to the membrane. That work was mostly done by Daniel Bichet's group in Montreal. You can see that this compound here does in fact get more V2 receptor to the, in this case, the basolateral membrane. The problem is this is also a V2 receptor antagonist. So you're getting it to the membrane with a product that inhibits the function of what you just got to the membrane. So the concept is there, but unfortunately this isn't going to go anywhere, and V1 receptor antagonists don't work as chaperones. It would be so hopefully somebody will come up with a V2 receptor-like molecule that will get it to the membrane but not actually inhibit function. Another product that's been tried is erlotinib. Again, this is actually just published, I believe, this month in the Journal of the ASN. Erlotinib is often used in chemotherapy. It's a selective EGFR inhibitor. This group, this is again Dennis Brown's group, showed that erlotinib increases aquaporin-2 expression in the collecting duct principal cells and reduces urine volume by nearly 50% in mice, in this case with lithium-induced NDI. The problem with erlotinib, and certainly the oncologists in the audience would know, this is not without side effects. It's a fairly toxic medication, so to really take otherwise normal, healthy kids and put them on a product with this many side effects probably is not going to be the way to go, but it is an intriguing proof of concept that perhaps a less toxic EGFR inhibitor could be useful. Another approach has been the use of something called ONO AE1329. It doesn't have a nice catchy name. People call it ONO because it's easier to say. At any rate, the concept here was to see if there was another GS-coupled receptor which would activate pKa. Again, remember that the V2 receptor leads to the activation of protein kinase A. So maybe there's another receptor that, when activated, would lead to the generation of pKa. And the EP4 prostanoid receptor is one that's expressed in the collecting duct and could do this. Now, in another paper that just came out this month, again from Dr. Yang here in Utah, they showed that EP4 receptor increases the prorenin and prorenin receptor, which increases aquaporin-2 protein in the collecting duct. ONO increases urine osmolality in V2R knockout mice, and the effect was greatest at 1 day and then begins to dissipate a bit. The problem here, the limitation, is that this ONO product has very poor solubility and is relatively unstable in aqueous solution. But a better version of this, or perhaps something working through prorenin, a prorenin receptor, which undoubtedly would be work coming out of this institution, could yield that this is a therapeutic approach to pursue. Another piece of data that's again from this institution, this is work by Dr. Kishore, is looking at clopidogrel. Many of you have used clopidogrel, or Plavix is the brand name, and Dr. Kishore's group showed that this improves osmolality in lithium-induced NDI rats. Clopidogrel activates the P2Y12 receptor, signals through a different G protein, GI, to decrease cyclic AMP. So clopidogrel is a selective inhibitor. And in lithium-fed rats, clopidogrel reduced polyuria, decreased urine osmolality, and increased aquaporin-2 abundance. So this suggests that P2Y12 receptor blockade increases DDAVP stimulates cyclic AMP production and could be a therapy for lithium-induced NDI. Now, one of the differences between lithium-induced NDI and congenital NDI is in lithium, there's certainly some endogenous vasopressin around, and there is some activation of cyclic AMP. The dose-response curve is markedly shifted, but there is something there that could be activated, and so clopidogrel or Plavix could be very useful in the lithium NDI patients. Finally, my group has been looking at metformin. And again, most of you have probably prescribed metformin for type 2 diabetes. It's also used in non-diabetics and women with polycystic ovary syndrome. It's been around forever. Metformin activates AMP kinase. It doesn't do so directly, but ultimately increases AMP kinase and is involved in cellular energy balance. It can stimulate NKCC2. Remember that protein I showed you in the thick ascending limb that's critical for the entire concentrating mechanism, and it can do so independently of vasopressin. And in a paper earlier this year, we showed that AMP kinase can activate both aquaporin-2 and UTA1 independent of vasopressin. So does it do anything in NDI? We did a study published this summer in which we took animals and made a chemical knockout of the V2 receptor. We basically took tolvaptan, which again, many of you have probably used tolvaptan. It's a selective V2 antagonist. And let me walk you through this experiment. So here on day 1, we measure baseline urine osmolality in all the rats. On day 2, they're all given tolvaptan, and you can see about a 50% reduction in urine osmolality. This is done for up 3 more days, so we have a stable inhibition of V2 receptor function and a reduction of urine osmolality. Beginning here on day 6, in the dark green bars, those animals are they're all continued on tolvaptan, but the dark green bars also get metformin. And you can see after 2 days of metformin, continued out to the end of the 2-week protocol, urine osmolality with metformin has come back up to the control levels, while that of the tolvaptan-only animals remains at about 50%. So this suggests that, in fact, metformin can increase urine osmolality in the NDI model and is sustained for up to 10 days. And clearly a therapeutic for a congenital condition or for lithium, which is usually irreversible, you're looking at lifelong therapy for those subjects, so it has to be something that's sustained. And we're very encouraged by this, and with any luck, our grant that was sent in to do the clinical trial of this in pediatric populations will get funded, and maybe in a couple of years we'll have some data. So in the last portion of this talk, I want to turn to some other very common clinical conditions in which water channels play a role. We'll start with congestive heart failure. In animals, the model is a left coronary artery ligation. Believe it or not, the rats don't die. And if you tied off a person's left coronary artery, they're dead. I mean, this is almost the widowmaker lesion. But the rats don't die. And in fact, not all of them even get an increase in LV-EDP. So the authors have to measure this by ultrasound because there's variability in the increase, and but it does go up. They, like people, they get serum hypoosmolality of about 7, and plasma vasopressin increases in these animals. So this is, just like we read about in the textbooks, non-osmotic release of vasopressin. What happens to the aquaporin 2 water molecules? This is work shown here in which heart failure does increase aquaporin 2 amount and apical membrane localization. So I've shown you now that in normal animals, when you give vasopressin, you move aquaporin 2 to the apical membrane and you increase the abundance of the protein. Well, in heart failure, vasopressin is up and aquaporin 2 responds just as it would in a normal animal. That is, you get an increase in the apical plasma membrane expression of aquaporin 2 and more immunoreactive protein. Is this really due to a V2 receptor effect? And the answer is yes. This is work from Bob Schreier's group in Denver. They again did sham operated animals, congestive heart failure animals, and the heart failure animals treated with the V2 receptor antagonist, and you see less immunoreactive protein. So it would be logical if you're trying to improve hyponatremia in heart failure patients that a drug like tolvaptan would be beneficial. In fact, it is, but I think, as everyone knows, the cost of daily therapy with tolvaptan is beyond what most people can afford. But on the physiologic level or pathophysiologic level, it actually makes sense. Just go on. Another condition that we frequently see is ureteral obstruction. So in these studies from Denmark, this group of Jørgen Frokjer and colleagues in Denmark did, in various papers, they did either unilateral or bilateral ureteral ligation. They do it for 24 hours and then they release the obstruction. The rats, like people, develop a post-obstructive diuresis and free water clearance is reduced. But when you look at what happens to aquaporin 2 and urine output, I think this is very important. and really shed some clinical insight. Let's first look at the bottom part of this figure. Now this is a bilateral, from one of their bilateral ureteral obstruction papers. Here's urine output. In the open bars are sham-operated animals. So urine output is stable. There's no reason it should change, and it doesn't. At the end of the 24 hours of obstruction, there's of course no urine output because they tied off both ureters. 24 hours later, you can see a marked increase in urine output. This is the post-obstructive diuresis that we're all used to seeing. 48 hours after obstruction, it's a little bit better, and a week later, it's back to control levels. But look at aquaporin 2. Here, again, in the open bars are the sham-operated animals. This is set to 100%. When you take kidneys out of animals at the 24-hour point, when you relieve the obstruction, it's down to 25%. 24 hours later, still 25%. 48 hours later, still 25%. But notice here at 7 days, it's still only 50% of normal. So even though urine output has now come back to the control level, the kidney has not healed at 7 days, as evidenced by the aquaporin 2 abundance still being 50%. And I think clinically we're all very aware that in the post-obstructive patient, they're very susceptible to any new bout of dehydration or volume depletion or any other acute kidney injury. And in part it's because although the urine output's normal, the kidney still has not completely healed. So I think that's part of why the classic teaching is absolutely right. We have to be very careful with these individuals until, not just till urine output is normal, but until their kidney has time to completely heal. So aquaporin 2 decreased in the obstructive kidney at 7 days. The excretion of solute in water may be nearly normal, but aquaporin 2 is still only at 50%, and it explains the kidney's vulnerability to volume depletion. In the last little section, I wanted, Alfred mentioned us getting older, being old friends. It also means we have old kidneys. And as this is a topic that is, I think, Alfred last night at dinner was saying that when he was a resident, he didn't really think much about aging because, you're young and, we're all going to live forever and be fine. Unfortunately, we all do get older. And so the kidney gets older, and there are changes in the kidney that occur with normal aging. Aged individuals are unable to concentrate their urine as well as younger individuals, which makes these as we get older, we become more susceptible to hypernatremia. And this is not really news. If you look back at the Baltimore longitudinal study of aging published in the 70s, they show that with aging, as you get over 60, you begin to lose the ability to concentrate your urine. It's part of why our older patients are getting up at night to urinate, and unfortunately they can fall and break their hip, and there's significant morbidity that comes with that. But in fact, there is an aging-related concentrating defect that, because of not so much the defect, but because of the consequences of falling at night, is significant. So we looked at this. This was done in collaboration with Celia Sladek's group. We looked at 4-month-old and 30-month-old rats. Now, a 4-month-old rat is like a teenager, and a 30-month-old rat is really old. I mean, most rats don't make it much beyond 2 years, but you can buy these animals from the National Institute on Aging. And we water restricted them for 3 days. And let me show you some of what we found. So the way this is shown, here's the age, the 4-month-old, the 30-month-old. Hydrated in this case is not that we water loaded them. These are just rats running around the cage. They don't lose any body weight. Here's their hematocrit, plasma sodium, pretty normal, urine osmolality. When you take these younger animals and dehydrate them for 3 days, they lost 8% of their body weight. They get hemoconcentrated, hypernatremic, and their kidneys are doing a remarkable job of concentrating the urine. Now let's compare that to the older animals. Again, the hydrated are just ad libitum animals, so they don't lose body weight. Hematocrit is roughly the same as the younger ones. They were a bit more hypernatremic than the younger ones, and the same urine osmolality. But when you subject them to 3 days of dehydration, they lose 6% of body weight. They again get hemoconcentrated, about the same increase as the younger ones. But look at what happens to plasma sodium, 163. So this is serious hypernatremia in these animals, and at least in part it's because they can't concentrate the way the younger ones. So I'm sure you've all seen this, that the older patients are much more susceptible to hypernatremia. Now, in part, this is because the aquaporin 2 does not increase in the inner medulla of the aged animals the way it does in the younger ones. So here's the 4-month-old animals, here's aquaporin 2, it doubles with 3 days of dehydration. Here's the older animals, at baseline about the same aquaporin 2, but no increase whatsoever with dehydration, consistent with the lack of increase in urine osmolality. Now we went on, both groups of animals had similar pituitary vasopressin stores, but the older animals did not increase plasma vasopressin levels during water restriction. So this could be part of the explanation, is it seems to be that the older animals have a central component in that they do not increase vasopressin levels, but they also have a nephrogenic component because they were unable to increase their aquaporin 2 protein. And this is probably what contributes to the concentrating defect and hypernatremia in the older animals. So let's finish up by going back to the patient that I started with. What can you offer this individual? Or any individual with nephrogenic DI. They have to drink enough water to match the urine output. Thiazide diuretics are the standard therapy for nephrogenic diabetes insipidus. Now you're probably scratching your head and saying, why would you give a diuretic to somebody with nephrogenic diabetes insipidus? Well, if you give a thiazide coupled with a very low sodium diet, 0.5 grams, this is a quarter of what you want your heart failure patients to take, you get a mild volume depletion. The mild volume depletion will stimulate the proximal tubule to reabsorb 80% of the glomerular ultrafiltrate instead of 60%. So you decrease distal delivery, and there's just less potential fluid to become urine. So you actually can improve urine output with the thiazide and a very low sodium diet because you've increased proximal reabsorption and decreased distal delivery. Non-steroidals are often used, but these are nephrotoxic. They obviously can harm renal function. They have GI side effects. You can stop the lithium, which is what in general I recommend when I'm called by my psychiatric colleagues, and they can go to another agent. The problem is that, as I mentioned, the lithium-induced effect doesn't go away when you stop the lithium, so that patient still has that problem, and other agents may not treat the bipolar disease as well as lithium, and patients who are nicely controlled on lithium are usually very reluctant to change their antipsychogenic psychotropic medication. So in summary, the cloning of the V2 receptor and aquaporins provide the basis for understanding congenital NDI. They also permitted tremendous progress in our understanding of cellular mechanisms by which vasopressin regulates water absorption in the collecting duct, and will hopefully lead to future therapeutics that can make it to the bedside. I've mentioned some of my collaborators for the portions of this talk that came from my own group, and of course need to thank NIDDK for paying for it. Thank you for your attention, and I'd be delighted to answer questions.
Well, this is one of the most cogent bench to bedside talk, especially regarding the V2 to aquaporin axis I've heard. I'm sure Jim Kushner would appreciate it. I really thoroughly enjoyed the talk until the part he's talking about aging. Then I'm not sure I like it that much anymore at that point. Anyway, questions? Yeah, Matt. Matt, I'm sorry. Matt?
Yeah, I wasn't sure last time I did.
Oh.
I'm not using the microphone.
Oh, I see.
But I'll just
Yell really loud. Okay.
I'll talk really loud. I was really interested in the data with clopidogrel and was wondering in those experiments or others if the dose of clopidogrel that's been studied has been similar to what we use clinically for cardiovascular disease, or if it's a different.
Same dose of clopidogrel or not?
So, I have this one, yeah. So the question was whether the clopidogrel dose was similar to what's been used in people. I believe that that is the case, that it's a similar dose. Again, those studies were actually done here by Dr. Kishore's group. Is it the same?
We need to adjust to according to the body surface, but I think it works. We have learned those
So for those who did, Dr. Kishore said they actually have corrected for body surface area. It's comparable, but they also now have lower dose data as well.
Other questions? Oh, one back there. Oh, Corinne.
Why IV vasopressors really don't interact with the V1 and not V2 receptors, is it concentration of dose issue, or is it some other reason?
Just briefly repeat the question.
Yes, so the question is why when you give IV vasopressin that you're mostly seeing a V1 effect and not so much of a V2 effect. I assume you mean in the ICU setting when you're using it as a vasopressor. That's actually, it probably is a dose effect. It's also that IV, it's going directly into the vasculature where the V1 receptors are located, and I suspect in many cases there are other reasons that the kidney just is not responding. The V2 effects are less noticeable than the V1 effect. So it's primarily, as you suggest, a dose effect and the fact that you're delivering it initially to the vasculature in a much higher dose than normally would be seen by endogenous vasopressin.
I just have one final clinical question. Amiloride, does it do any good for concentration or the chronic toxicity?
So amiloride, as you know, is an inhibitor of the epithelial sodium channel. And amiloride has actually been used, amiloride is useful in a number of settings. It is useful as an antihypertensive. Certain forms of genetic hypertension, particularly Little syndrome, where you have overstimulation of ENaC, amiloride is particularly useful. It has been advocated for the treatment of nephrogenic diabetes insipidus. And it's interesting there because lithium actually enters the cells on ENaC, or the epithelial sodium channel. So if you use amiloride early in the course, you might prevent the uptake of the lithium into the cells and potentially reduce toxicity. And a study that I did a number of years ago with a group in New Zealand, we tried amiloride in an animal model as sort of primary therapy, and it did seem to work by decreasing the buildup of the lithium. The problem with amiloride in NDI or any other diuretic is you run the risk if there's some dehydration or volume depletion of raising lithium levels in the plasma. So if you, and there's a very narrow therapeutic index for lithium. So amiloride in theory would be good for NDI, for lithium-induced NDI, but probably using it late in the course of, after established patients been on lithium for many years, limited benefit. What would be more intriguing would be to try it right from the start. So I think lithium, and as long as they don't then, the other time you can see these patients get into trouble, whether they're on amiloride or not, is they get a URI, they get gastroenteritis, they get volume depleted, and now their lithium levels go up, and they can go up actually into the toxic range. So it's tricky. It can be done. In theory, it should work. In practice, it's a little hard to manage.
Thank you very much.